I am Valentin Fuster from New York, and I'm very pleased today to chair this particular meeting, as we do every year after the national meetings, and that is a summary of what has been going on in Atlanta in the scientific sessions of the American College of Cardiology. As usual, I am surrounded by real experts in different fields that will be discussed, and I'd like to introduce them. In my right is Dr. Clyde Yancy. He's the Vice Dean for Diversity, Equity, and Inclusion, a Magistrat Endowed Professor and Chief of Cardiology and Professor of the Department of Medical Social Science at Northwestern University Feinberg School of Medicine in Chicago. Lots of titles. Now we have here Dr. Julia Indik. She's an electrophysiologist at the University of Arizona in Tucson. She's the Flame Foundation and American Heart Association Endowed Chair in Electrophysiology. Welcome, Julia. We need a surgeon, of course. And he is Dr. Vinod Thourani. He's the Bernie Marcus Chairman of the Department of Cardiovascular Surgery at the Piedmont Healthcare and the Marcus Heart and Vascular and Valve Center at the Piedmont Heart Institute here in Atlanta. Welcome.
Thank you.
Welcome to your city.
Thank you. Very short drive.
That's right. 10 minutes,
That's
you told
right.
me. And finally, from London is Dr. Rasha Al-Lamee. She's a deputy editor of Eurointervention and an associate editor of the European Heart Journal. She's a deputy director of medicine at Imperial College in London, and she's an interventional cardiologist. Well, here we are. How we are going to approach this? First, we will go to 3 tough papers. I would say tough patients to deal with. And then we'll go into metabolic diseases. We end up with some coronary artery disease and hypertrophic cardiomyopathy, whatever the time permits us. So why we don't start? And actually, this was the first presentation in the meeting, and was the RELIEF-HF trial. Was a double-blind, randomized, placebo procedure-controlled trial of an interatrial shunt in patients with heart failure, reduced ejection fraction, and heart failure with preserved ejection fraction. The paper was presented by Dr. Greg Stone. Well, let's begin to talk about basics here. Heart failure is characterized by an increase in left atrial pressure and pulmonary venous congestion. And here's the situation. An interatrial shunt may provide an autoregulatory mechanism to decrease left atrial pressure and improve heart failure symptoms and actually prognosis. So here we have the objectives in trial design. The investigators sought to determine the safety and effectiveness of the V-Wave Ventura interatrial shunt device in symptomatic heart failure patients with any left ventricular ejection fraction. This is important. In a randomized double-blind placebo procedure-controlled multicenter trial, as we mentioned. Given the uncertainty as to whether the response to the shunt would vary according to systolic function, patients were divided in those with an ejection fraction equal or less than 40% and those with an ejection fraction of more than 30%. My colleagues will describe this Ventura interatrial shunt, but certainly is the connection between the left atrium and the left and the right atrium. It's a small shunt. Inclusion criteria: ischemic or non-ischemic cardiomyopathy with any left ventricular ejection fraction and heart failure for at least 6 months. Heart Association class 2, 3, or ambulatory IV functional class, class 4 functional class, despite maximal tolerated guided directed medical therapy. Exclusion criteria: patients with high pulmonary artery pressures, and the wedge pressures actually were not very high. We will discuss this. Okay, comparison between groups in a hierarchical composite ranking: all-cause death, cardiac transplantation or left ventricular assist device, all heart failure hospitalizations, all outpatient worsening heart failure events, or change in the Kansas City cardiac failure functional class. And these are actually the 5, in a hierarchical way, the 5 endpoints that were looked at. And then they also look first at 6 months and then at 12 months, with the longest follow-up at 24 months. Well, here we are. Primary safety endpoint, the device-related or procedure-related, all-cause death, stroke, systemic embolism, or need to open cardiac surgery or measure endovascular surgical repair at 30 days was compared between both groups. Numerous additional secondary safety endpoints were presented. This is actually, from the methodology point of view, this is a complex study. So I tried to summarize in the best way I can. Let's go into the study. 508 patients, they were randomized. 250 with the shunt, and 258, they had a placebo procedure. In terms of low ejection fraction, equal or less than 40%, there were 40% of the patients. 60% had an ejection fraction of more than 40%. Results. Risk of all cardiovascular events. We are all excited, see what happens. No difference. So, but let's not to be depressed. Let's continue. Then we have each of the endpoints that I mentioned look individually, where was no difference. Symptomatology, no difference. So you might say, well, that's it. Let's go to the next paper. And now comes the real difference. Left ventricular ejection fraction equal or less than 40%. The group that was shunting did much better. We are talking hazard ratio of 0.93 versus 1.92 placebo. And on the ejection fraction more than 40%, the results were actually completely the opposite. And this is interesting. What means is good news when the ejection fraction is low, bad news when the ejection fraction is actually high. So here's the conclusion. Transcatheter implantation of the Ventura interarterial shunt was safe but did not reduce symptoms or improve prognosis through 2 years in patients with heart failure across the full range of left ventricular ejection fraction. The results from a pre-specified stratified analysis suggest that interarterial shunt implantation is beneficial in patients with reduced left ventricular ejection fraction and harmful in patients with preserved left ventricular ejection fraction. Well, my friend, Dr. Yancy, tell me, are you going to use this device in the future?
No.
All right.
We need to do more research.
Okay, let's this is a good start. Go ahead.
But in all candor, we need to think about what are we trying to solve? And what we're trying to solve is to decongest the left atrium. That's really what's driving symptoms in heart failure, whether it's HFrEF or HFpEF. The dilemma is doing such on top of already standard medical therapy, particularly for HFrEF, and emerging standard therapy for HFpEF. Is there an advantage? We have to be careful. If we interpret this at face value, it gives us pause and says perhaps this is not appropriate for HFpEF. I'll get back to that in a minute, but we also need to be circumspect. We understand that when the primary result of a clinical trial is null, and we get into secondary analysis, they can only be interpreted from an exploratory perspective. We can't use them as the definitive statement. Now, to really tease everyone, what might happen here is that, yes, they excluded those with pulmonary hypertension, but we know that the sine qua non for this diagnosis of HFpEF is the exaggerated increase in PA pressures with exercise. And if you create a left to right shunt, I know Vinay is saying, you did what? You made an ASD? If you create a left to right shunt in a circuit where there's already pulmonary hypertension, obviously patients wouldn't do well. So there is plausibility if it's true, but there's also concern that we need to pause for a minute, because remember, the interactive test between HFrEF and HFpEF was not statistically significant.
Right. Dr. Thourani, you like all of this?
I 100% agree with Clyde. I think that you have to take the face value of the primary endpoint, and once you start doing secondary analysis, you have to be careful in making those claims. I also think that you have to investigate. We do this sometimes when we do MitraClips. We keep a little bit, in transcatheter valvular disease, we leave these open. We create that little small ASD. It's like a little shunt. And if I have to deal with it surgically, I do close that small PFO or ASD that's been created, which is really a shunt. I also am worried about the RV. I think that's something we have to look at, is what happens to the RV when you create this shunt. Right. And I think that that's not been investigated very clearly. So pulmonary hypertension, RV, the interaction of all of this, I think we're just starting this process. I think we need to investigate, Clyde, like you said, a lot more. But am I ready tomorrow to have our cardiologists do this every day? I would say no.
Well, the good news is that we have ongoing studies. And so the investigators that are actually investigating other types of platforms can take this in and decide, do we need to do an interim analysis, think about safety, look at the characteristics.
Absolutely.
Rasha, what do you think?
So I totally agree with the clinical perspective. I don't think anyone's going to be using this device. But sometimes I think from a clinical study, you learn more than anything around the actual disease process or the device. And for this clinical study, I think we learned about trial design. The fact that they used a placebo procedure as a control arm is kind of dear to my heart, because that's the kind of research I've been trying to promote. But if you look at that Kansas City questionnaire, you immediately see symptom improvement. And you can imagine a scenario where they had an unblinded trial and we didn't have the placebo arm. You might have said, this is a trial in which the heart failure symptoms improved. But because they have that placebo arm, we see it's all placebo effect. And so just the trial design was a kind of interesting thing that I think we can learn from.
So, Julia, you have the final word, the summary.
Well, I think all these trials are very intriguing and expand our horizons of understanding what's possible. Understanding the physiology is the underpinning of it all. And when you see results that are surprising, you have to ask why and understand more deeply. So kudos to the investigators for putting this together.
Well, I think the summary is clear. We look at this study with interest, very, very complex from the methodology point of view, but we are not ready. Is this correct?
Correct.
Okay, let's go now for the next one. Okay. Yeah, the next one is an interesting study, is the IMPACT-MI trial, left ventricular function, congestion, and effect of empagliflozin on heart failure risk after myocardial infarction. This was presented by Dr. Javed Butler from the Baylor Scott and White Research Institute in Dallas. Well, let's see what we have to say about this particular study. These patients, we are talking about patients with acute myocardial infarction with a hypothesis that the patients that present with an acute MI and are at high risk of heart failure may benefit from treatment with an SGLT2 inhibitor. I'm not surprised because SGLT2 inhibitor works on everything. So I'm not sure it's a hypothesis or it's already a reality. Okay, let's look at. Here we have in the IMPACT-MI trial, patients were randomized within 14 days of an acute myocardial infarction, complicated by either newly reduced left ventricular ejection fraction of less than 45%, congestion, or both, to empagliflozin 10 milligrams daily or placebo, and follow for a median of 17.9 months. Among 6,500 patients, 40% presented with a left ventricular ejection fraction of less than 45%, 23% presented with congestion alone, and then 33% presented with both. Endpoint, all-cause death, and heart failure hospitalization, meaning the first heart failure hospitalization or total heart failure hospitalization. Empagliflozin, and these are the results, reduced the risk for first hospitalization with a hazard ratio of 0.77 and total hospitalization with a hazard ratio of 0.67. Interestingly, this irrespective of the left ventricular ejection fraction and irrespective of congestion. The safety profile of empagliflozin was consistent across baseline left ventricular ejection fraction and irrespective of congestion status. So in patients with acute, this is the conclusion. In patients with acute myocardial infarction, severity of left ventricular dysfunction and the presence of congestion was associated with worse outcomes. Empagliflozin reduced first in total heart failure hospitalization across the range of left ventricular ejection fraction with and without congestion. I have to point out that the endpoint of all-cause mortality was actually not reduced. Okay, so Rasha, what do you think about the study?
I think it was a surprise, right? This was one of the most surprising studies of the meeting for me. The SGLT2 inhibitors have been the wonder drug for some time, and I think the investigators tried to put things into context. Obviously, it was good to see heart failure hospitalizations reduced, but we were surprised not to see all-cause mortality change. And I think they've published multiple different papers now that we need to look at and understand why that happened and why we had a result that was different.
Thank you. Julia, what do you think?
No, I agree, and this has become the new wonder drug, just as you've said. All it depends on like the exact patient population that you pick, and the emphasis on looking at patients with a depressed ejection fraction to start with. I think myself, I'm not that surprised that there was no difference across the severity of the ejection fraction, but just with the presence of a lower EF or congestion. So for me, I guess I wasn't that surprised. The lack of a mortality benefit, yes, is somewhat surprising, but I think if I recall right, with dapagliflozin, there was a questionable other difference.
Yeah.
So more to the study, more to the story.
You have in the operating room SGLT2s ready to give to any patient you operate?
No, you know, I was thinking about how we have spent a lot of energy and time on patients who are getting medical therapy and the new inhibitors, but we're not in cardiac surgery. And we cause damage by just going on the cross clamp and going on cardiopulmonary bypass. We've completely forgotten these patients. Coronary bypass surgery is still the most common procedure done in the United States for cardiac surgeons. And we have not investigated these drugs and how they decrease mortality in hospitalization. I think that's fraught for new research down the road.
Give us a summary.
So here's a different point of view, and this is the summary. I'm not surprised because the mechanisms of death after acute MI have very little to do with the imputed mechanisms of benefit of the SGLT2 inhibitors. But I am relieved, in fact pleased, because this is a trial about IMPACT, but not EMPACT, IMPACT. Think about this. 90% of the patients had immediate revascularization. 98% ended up with dual antiplatelet therapy. 90% on statin therapy. Multiple countries. This is evidence that our standard of care for an acute MI is very, very good. So that's IMPACT in my mind. That tells me that we're in a good place. And trying to make that better with any agent is going to be very difficult. And the agent did what it's supposed to do, longitudinally attenuating the risk of heart failure. There's nothing about those drugs that should have done anything about acute remodeling injuries. There's nothing about reperfusion injuries. It's everything about protecting the myocardium. So the results played out like I wish they would have. This makes it a little bit easier.
So Clyde, do you think that bar is already so high, it's going to be hard to get any further higher than that bar?
And the investigators experienced that.
Yeah.
The event rates were very low. They had to increase the recruitment up to 6,000 and extend the recruitment to try to accrue enough events. So I think they were learning real time. We were already doing something quite well as a standard of care internationally, and we don't see that often. So I think that's a different kind of impact.
Yep.
So let me ask you, are you going to use this approach?
Of course not, because we have a standard of care that works. Now, for any patient with LV dysfunction after an MI, because remember what else they did? They enriched the patient population, which makes it even more compelling. They looked for those at high risk for heart failure, didn't see the early signal, but did attenuate late onset heart failure. So it adds to the body of information that these drugs are great for either preventing or treating heart failure. not so much for acute MI care.
Right.
Yeah.
Well, thank you very much. What we have is two interesting studies, but are not really convincing to you that it's going to change practice.
Not at all.
Agreed.
Okay, this is the summary. Well, let's see the next one. Interesting. The next one is the microaxial flow pump, or standard care in infarct-related cardiogenic shock. So let's see what happened. Basically, this is a percutaneous approach that connects the left ventricle with the left atrium. And the question is, has been a lot of literature about this in patients with shock, but they decided to do this well in a randomized fashion in patients who actually had cardiogenic shock with myocardial infarction. This is an international multi-center randomized trial that were patients with a STEMI and cardiogenic shock to receive the flow pump, the Impella CP, plus a standard care or a standard care alone. The primary endpoint was death from any cause at 180 days. A composite safety endpoint was severe bleeding, limb ischemia, hemolysis, device failure, or worsening aortic regurgitation. The number of patients, 360 patients, underwent randomization, and 179 in the flow pump, 176 in the standard care group. Median age of the patients, 67 years, and 79% were men. And here's the story. Here are the results. Death from any cause occurred in 45% in the flow pump group and 58% in the standard care group, with a hazard ratio of 0.74 and a p-value of 0.04. A composite safety endpoint occurred in 24% in the flow pump group and 6% in the standard care group. Renal replacement therapy was administered in 41% on the patients in the pump and 26% in the standard care group. So we have a dichotomy here, but these are the conclusions according to the paper published in The Lancet. The routine use of the microaxial flow pump with the standard care in the treatment of patients with STEMI-related cardiogenic shock led to a lower risk of death from any cause at 180 days than a standard care alone. The incidence of a composite of adverse events was higher with the use of the flow pump. I feel ambivalent. How do you feel?
I'm encouraged for one reason. We have desperately sought randomized data to let us know that this kind of temporary mechanical circulatory support wasn't causing harm and had a signal of benefit. And you're right, it is a dichotomy. There are complications associated with this. But despite the complications, it's still seen to prevail. And let's remember, thinking about the AMI discussion, cardiogenic shock is a bad outcome after an acute MI.
Well, Dr. Thourani, I feel, when I say I feel equivocal, is the number of events and complications is pretty high here.
So, you know, I think of this like Clyde, in the sense that I'm actually encouraged by this. Unlike the bar that we talked about in the previous study is already so high, it's hard to make that incremental change. The bar here is a lot lower. And so I'm encouraged that idea that mortality has a significant benefit. We can always work on the complications. I think technology will need to catch up. And the company and other companies will need to figure out how do we decrease those adverse events. This is a technology issue as far as vascular events, as far as renal replacement. The pumps need to be smaller. Peripheral vascular disease is prevalent in these patients. We need to figure out how do we make the devices smaller with less complications. So I'm encouraged by this. Mortality is significantly better. That, to me, is a huge bar that we have overcome. Now we need to work on the adverse events. And to me, I think that's doable. And I think with technology modifications, I think that's very doable. It reminds me of TAVR in the early days. We went from a 24 French sheath down to a current 14 French sheath. And there's new valves with 8 French sheath. But we're seeing the mortality benefit. That's a higher bar that they've overcome.
Thank you, Julia.
So, I mean, I was struck in this trial about being super careful on the patient population being studied. They excluded people who are comatose after cardiac arrest, looking at people with a high lactate, a group that might be most likely to benefit, and also in those who are randomized to get the microaxial flow pump, there was somewhat less upgrade to VA ECMO compared to the non-microaxial flow group. And some of the adverse events just may be, at least part of it, related to improve. They lived longer to accrue the adverse events. So I agree. This is, I think, rather encouraging. And to find some way to improve the bar, even by just 10% in mortality, is a huge event.
Thank you. Rasha?
Yeah, so I think from my point of view, I kind of would like to bring the kind of European perspective to this. So there's been a real difference in practice. In the US, of course, Impella has been used, very widely used, was adopted very, very early. Whereas I think in Europe, we've been a lot more cautious. And certainly in the UK, it's really not used to a great extent because we were waiting for RCT data, which we didn't have in a population of patients that were very high risk, the cardiogenic shock population, as opposed to just kind of high-risk PCI. So with this, I think it's very interesting, and I think there'll be centres. I see it already in our own centre where we really don't have access to Impella. There's a discussion now about, is it time to bring it in? But that's caveated with, exactly as you said, how do we technically make sure that we minimise our complication rates? So I think this will have impact on practice in areas where we haven't had access at the same level.
Well, excellent. From these 3 presentations in very sick patients we are talking about, or at least patients with heart failure and the patients that we are now discussing, it seems to me this is the paper that perhaps has the more positive results in terms of changing practice.
You're exactly right, because realize that all of the predicate information kept informing us that there was harm and not much benefit.
Yeah.
Even the simplest strategy, intra-aortic balloon pumps, we've never had a positive trial. And so I commend the investigators, and I'm in this space. This is a hard trial to do. These are desperately ill patients. Minutes make a difference. So to execute this trial, end up with something that we can operationalize, I think that's at least intriguing.
Yeah, absolutely.
Okay, thank you very much. So let's move now into 2 types of patients that are not really so desperate. So let's talk about HDL.
The 3 hard ones are done now, Val.
Let's talk about HDL again. We talked for the last 30 years and goes up and down. So, and then we'll talk about hypertension just to. Let's move to the next paper then, or the next presentation. This was the AEGIS-II study, effect of CSL112 on recurrent myocardial infarction and cardiovascular death, insights from the AEGIS-II trial. It's an HDL trial. And this was presented by Dr. Michael Gibson from the Boston BI Deaconess. Well, we all know the story about HDL. Looking at the concentration of HDL, meaning if it is high, epidemiologically speaking, is good news. If it is low, epidemiologically speaking, is bad news. Then come treatment with the high levels, and nothing is found in terms of outcomes. So it has been a story of 20 years. But something came out in the last 10 years, which I think is important, is rather than looking at the concentration of HDL, is looking at what the HDL is doing. And what HDL is doing is getting really the cholesterol, the bad cholesterol, and sending it out. It's a function. And let's look at the function rather than the concentration. And this is basically what this paper is all about. Let's now go into the details. CSL112 is a human plasma-derived apolipoprotein A1, ApoA1, the primary structural and functional component of HDL, formulated for intravenous infusion. CSL112 improves cholesterol efflux after infusion. An early clinical evidence suggests that single infusion have been associated with acute changes in plaque morphology, including reductions in lipid content, macrophage size, and necrotic core. There are a number of studies, small studies, suggesting that something happens to the atherosclerotic plaques when you use this approach, which is then looking at the enhancement aspect of HDL. Well, let's go into the methods. The AEGIS-II trial was an international multi-center randomized double-blind placebo-controlled trial that randomized 18,000 high-risk acute myocardial infarction patients to 4 weekly infusions of ApoA1 or placebo. The incidence of the composite of cardiovascular death and type 1 myocardial infarction were 11 to 16%, were 11 and 16% respectively, lower in the CSL112 group over the study period. Hazard ratio 0.84, but didn't reach statistical significance with a p-value of 0.56. However, the effect of CSL112 treatment on myocardial infarction was predominantly observed for type 1 myocardial infarction and type 4B myocardial infarction due to stent thrombosis. They really look at different groups. And the study was close to be positive and was in a way close, very close to be positive, but was a short follow-up. Just over a period of 1 year. So these are the conclusions. While CSL112 did not significantly reduce the occurrence of the primary study endpoint patients treated with CSL112 infusion, had numerically lower rates of cardiovascular death and myocardial infarction type 1 and stent thrombosis-related myocardial infarction as compared to placebo. So I'd like to give my opinion on this first. I shouldn't do that, but I have been involved in this field. And it's very interesting, the aspect of the duration of a study and then the impact of the concentration that you are dealing with. For example, in LDL cholesterol, if you look at a 60-year-old that has an LDL cholesterol that is high, 150, who doesn't have family history, versus one who has 150, who has family history, they have the same level. The impact is much higher in the family history. And the issue is the duration, not the concentration. And here's the point. What is finding here is very close to significant, but it's only 1 year follow-up on hard endpoints. So what I'm trying to present is a positive view that in a long follow-up, looking at HDL, finally, on the functional point of view, may be the answer. This is all what I can say. So, Sarah, you don't look too convinced.
Yeah, I'm not convinced because of the numbers. This was a commendable trial. They did incredibly well to recruit so many patients. It's incredible that they are thinking of, we are thinking of new therapies for prevention, and that's definitely commendable. But when you have to treat these thousands and thousands of patients to see the smallest signal of benefit, you have to wonder what the clinical impact would be. And so from my point of view, I'm maybe a lot more cautious about that.
Julia?
I agree. And as far as the follow-up, but if my understanding of the treatment itself was just for a specific period of time, I don't know why I would expect 5 years later that treatment to have an impact. And I was also struck 18,000 people, and in the end it was only just going to approach significance, but not there. So I don't think we're quite there yet.
Clyde?
I'm intrigued again. I think we need to continue to pursue novel approaches. As Dr. Fuster said, for 30 years we've targeted HDL and have come up empty. But we know that in epidemiological associations, it is an important variable. Is this the way to get to it with ApoA1? And maybe we can partition the 18,000 and find the group. We've suggested the group with a very high LDL might have done better, and definitely longer-term follow-up. But I think it's necessary for us to continue to do this because despite my earlier comments, this continues to be a leading cause of death, particularly in industrialized countries and increasingly so in emerging countries. So I think we have to continue to pursue these kind of strategies.
Yeah, this is my view, actually. It's like, it's an opening door to a new approach to
Right.
HDL. Dr. Thourani?
No, I mean, I agree with you, Valentin, in the sense that we should have seen something, but the follow-up is just too short. I think you have to continue to follow these patients a lot longer. If this data was the same at 3 years, then I think you could end this conversation.
Yeah.
1 year is just not enough. I'm a little discouraged by the 18,000 at 1 year, but not 100%, because if they show something at 3 years, then I'll be a lot happier.
Thank you. So we call this cautiously hopeful, and this is my summary, but some of you cautiously not hopeful.
Yeah, but
Let's
keep
leave it.
working.
Keep working. That's exactly right. We all agree on that. Keep working on it.
Thank you. Well, now is interesting. The next paper, let me just see here. Yeah. This story is interesting. If you're asking me, one of the greatest problems that we have in medicine today, there are all the issues, disparities, the elderly people, and so forth. But to me, one of the key issues is adherence to medication. It's a huge issue. And this is why we develop a polypill based on, the FREEDOM trial, which, I was running in diabetic patients with multi-vessel disease, PCI versus CABG. I was so happy when we found the results, CABG. And then I look at adherence to medications, 20%. Yeah. And then I went into the VARI trial, it was the same thing. Mm-hmm. So what we are saying here is we do lots of things and we talk about lots of interventions, but the medical side is left a little bit out of your hands. Well, anyway, this is an interesting study on hypertension. We have many people with hypertension. Interesting, 50% of the population have hypertension, they don't know about it. And from these 50%, half are not treated properly. So we have a problem with adherence too. And this is the paper that I would like to discuss in the next few minutes. So this is the Kardia 2 study. Silebesiran in combination with a standard of care antihypertensive in patients with inadequately controlled hypertension. And here we are going to present the primary results from the phase 2 Cardiac 2 study. Yeah, the introduction is certainly hypertension and adherence is not good. So this is an investigation of subcutaneously administered RNA interference therapeutic targeting that really gets into the hepatic synthesis of angiotensin. What is fascinating is a single injection really not of this for a significant amount of time. Anyway, and there was preliminary data over the last 2 years, which was presented in the national meetings, that this approach could be meaningful. But all the data presented was in terms of what is the right dosage to use. And finally, they reached the conclusion that the right dosage to use is 600 milligrams in a single subcutaneous dose. And what they did is in patients with hypertension, are 3 different aspects of the study. In one, they used this single injection with a diuretic, indapamide, or with amlodipine, a calcium blocker, let's call it, or with olmesartan. So there was always a combination. And what they look is at the primary endpoint in a short period of time, actually 3 months. And then they follow this for a longer period of time. They also look at serum angiotensin, where it was dropped, and certainly they use ambulatory blood pressure as the main approach, but they also had a look at office blood pressure. I think it's an interesting study. Average age of the patients, 59 years. Average systolic blood pressure at baseline was not so bad. It's 143 millimeters of mercury. Very close ambulatory with office type of. And the number of patients that were actually studied was 1,500, a good number. I already mentioned the age. And let's start with what happened with angiotensin. Huge drop. So the concept appeared to be right. And this was already presented on a previous meeting in another study, but certainly here is very impressive. And here we have the results, and we can start with the ambulatory results of systolic blood pressure. When this is used with a diuretic, there is a drop in systolic blood pressure of 12 millimeters of mercury. When it is used with amlodipine, it's 10 millimeters of mercury. When it is used with olmesartan, is actually 4 millimeters of mercury. This is ambulatory. And then office blood pressure, very similar. Perhaps the reductions are more impressive, a little bit more impressive in the office. All right. Then there is a secondary endpoint, proportion of patients achieving systolic blood pressure response at 6 months without rescue medication. 64% when a diuretic was used, 39% with the amlodipine, and 26% when the receptor blocker. So the results are impressive because it's just a single injection. The safety profile was very good, actually. I'd like to read the summary as it was presented. Treatment with a single subcutaneous dose of silibesiran, 600 milligrams, was associated with clinically significant reductions in 24-hour mean ambulatory and office systolic blood pressure compared with placebo at month 3 when added to a diuretic, a calcium blocker, or a receptor blocker. These differences were sustained to 6 months in the group with diuretics and the group with amlodipine, but the results were not so significant in the group with the receptor blocker. The next question is, though the trial was not adequately powered to ensure long-term safety, these results support the potential for combining biannual dosing of silibesiran with a standard of care antihypertensive to achieve additive blood pressure reduction. Final point, the phase 2 cardiac 3 study has been initiated and will evaluate patients with hypertension uncontrolled by 2 to 4 standard of care antihypertensive who have high cardiovascular risk or advanced chronic kidney disease. Julia, what do you think about this one?
So if the point is to go after adherence, you still have to have people take a daily dose of some other drug. I kept asking and tell me more about monotherapy. So does this trial in the end going to achieve an ultimate goal of more adherence? I don't know, I'm asking that out loud.
Yeah, I'm not sure. It's a good point, Clyde.
So we've used words this morning like interested, intrigued, circumspect. I'm excited.
Yeah.
Yeah.
This is great science. This is great technology. Remember the phenotype, difficult to control hypertension. A systolic of 148, that portends significantly bad outcomes, stroke, kidney disease, and heart failure. And then a delta drop of 12. Let's put this in perspective. RDN, renal denervation therapy, is now a reality for difficult to control hypertension. You get about 7 millimeters of mercury. This is twice that. Exactly. And even if it is twice a year injection, I agree. This improves adherence. And you know what? Taking just a diuretic once a day
just
with
alone.
2 injections over a year, that's an easier sell.
Yeah.
And so I'm excited about this.
I am excited too,
Yeah.
I must tell you, because the same happened with lipid inclisiran, for example, which is an issue. There it can be used alone, maybe, going back to your question.
Right,
But
yeah.
I am as excited as you are. What do you think?
I'm the same. What I think most excites me is that we know with adherence that the more tablets, the less adherent the patient. And it's an incremental deal. And so for most of our patients, they're needing 2, 3 antihypertensives to be able to control their blood pressure. If you could just take 1 tablet and then the injection, adherence would certainly be better with the 1. And the other aspect that I think is exciting is, again, incrementally we know that the more blood pressure reduction, the better your outcomes. There's a big difference in terms of cardiovascular outcomes if we reduce blood pressure by 5 millimeters of mercury compared to 10. So I'm the same. This, for me, was one of the most exciting trials of the meeting, actually.
And it gets into the concept
Totally.
of adherence, which is a new approach.
And for me, an interventionist who's not in a space of hypertension, this was a new approach, totally new approach to hypertension, not interventional, which is nice to see as well, something that might be applicable in all kinds of healthcare systems across the world.
But you know, I think that this is really important. And of course, this isn't my space, but we're all touched by hypertension. Vein grafts go down with worse hypertension. Aortic dissections come with worse hypertension. So we're touched by it no matter what we do. And I actually think that this will have even more impact because patients get very upset when they're taking all these medications and they don't work. I think when you start to say, here's an injection twice a year that you can take subcutaneously in your doctor's office, they'll feel better about that the drugs are working. So I think this will have a mental effect. You know, when patients lose weight a little bit, they start to get encouraged. I think as their blood pressure drops, they'll get more encouraged, and hopefully this will change their lifestyle also. So I think that this may have more mental effects, which will help the patient work better at this. So I think this is very important, actually.
Julia, you made a good comment, and I'd like to comment, and that is you said these patients are taking another medication, so what about the adherence of the oral medication? Well, I know they are now going into patients with high resistance hypertension and so forth, but I see just the treatment of hypertension in a normal guy. You might not have to take any oral agent and just monotherapy, you know, a couple of injections a year, and the pressure is controlled. So I think the concept is quite fascinating and so on. Okay, well, exciting. Here I have a paper. To read it is going to be difficult because it's so they gave it to me. I'm trying to figure it out. But anyway, this is a very intriguing paper.
Okay.
It's the so-called PREVENT study from South Korea. The title in the Lancet is Preventive Percutaneous Coronary Intervention versus Optimal Medical Therapy Alone for the Treatment of Vulnerable Atherosclerotic Coronary Plaques, a multi-center, open-label, randomized controlled trial. Well, this is like going into plaques that they have an FFR that is not obstructive, and you see with OCT that the plaque has a little bit of fat and a small capsule or thin capsule, and you say, this is a vulnerable plaque, let's now do angioplasty and pacify the plaque just with the mechanical approach. Well, this has been going on, as you know, for the last 5 years, and results have been presented. But this is an interesting study, the way it was done with a significant number of patients. So this is the PREVENT, cannot see well, let me try. I'm sorry. PREVENT was a multi-center, open-label, randomized controlled trial done in 15 research centers or hospitals in 4 countries. And this is, as I mentioned, the study was actually led from South Korea, but also Japan participated, Taiwan, and actually New Zealand. Patients aged 18 years or older with non-flow limiting vulnerable coronary plaques with intracoronary imaging were actually assigned to either percutaneous coronary intervention plus optimal medical therapy versus optimal medical therapy alone. Follow-up continued annually in all enrolled patients until the last enrolled patient, which reached 2 years after randomization. Primary outcome, a composite of death from cardiac causes, target vessel myocardial infarction, ischemia-driven target vessel revascularization, hospitalization for unstable angina, and ischemia, and well, these are actually the endpoints. Now, the average follow-up was about 2 years. So between September of 2015 and September of 2021 was 5,500 patients actually entered into the study. For them, actually, that were really going into randomization for one reason or another was 1,500. They were assigned to percutaneous intervention of 500, and the rest was on placebo. And here are the results. At 2 years, the primary endpoint was 0.4% in the group treated with PCI versus 3.4% in those patients that were in the placebo group. And the question is how significant this is, but I can read the interpretation on the Lancet, or at least the summary, and it says patients with non-flow limiting vulnerable coronary plaques, preventive percutaneous coronary intervention, reduce measure adverse cardiac events arising from a high-risk vulnerable plaques compared with optimal medical therapy alone. And they go into the next statement. These findings support consideration to expand indications for percutaneous coronary intervention to include non-flow limiting high-risk vulnerable plaques. I only present you a question, and that is, were many patients that were going to enter into randomization, but it ended up with not so many. So I don't know how this is all selected, you know. And then the issue of the impact is also questionable. Anyway, I'd like to ask you, what is your first impression of all of this?
So I'm really glad to speak to this one. I really would caution the results of this trial. So the criteria for vulnerable plaque in this population was in the vast majority a lesion that was tight on IVUS or intravascular imaging that was used, or a significant plaque burden. It was actually a very small proportion of patients that had thin kappa atheroma, that had the various vulnerable plaque characteristics that we look for. And importantly, over 70% of the patients had grayscale IVUS, which is not very good at looking at these vulnerable features. I'm also worried that it was an open label trial and essentially the endpoints were driven by unplanned revascularization. And we've seen that in lots of trials before. So the story is kind of against the story that we've seen from other spaces. And the vast majority of the patients had stable coronary artery disease, which again, lots of other trials have shown us doesn't necessarily need kind of preventative therapy. So I'd be careful to consider this to really be a question of vulnerable plaque.
Thank you, Clyde.
In the parade of one words, frightening. Because if this is overinterpreted, I don't know how we control that. I like the idea of focusing on the plaque and deciding what plaques are stable, which ones are vulnerable. But if you extend this interpretation as they print it, that frightens me.
Are you saying don't put it in the guidelines? Is that what you're saying?
Adamantly not.
And I don't think they met a bar of vulnerability. That's not really what they studied.
Right.
And
I'm worried about the selection. Valentina, you said, I'm worried about the selection process. That just really, I think frightening is a good word for that. You can't have that large gap in the selection process. That is, for a randomized trial, that just doesn't make sense to me.
Mm-hmm. I would also just point out a couple of things. One, the LDL was about 90. We try to target and get people well below 70, so I wonder how good the medical therapy really was. And also the number of events, even in the standard of care, were not huge. I think it was like 3% or about 20 events. So this is, while it's statistically significant, we're talking about a small effect and probably not, maybe not adequate medical therapy.
I agree.
Yeah. We need to learn more about how we manage plaques, but let's say this is version 0.0 and go from there.
I totally agree.
I will tell you, Clyde, we are working a lot on imaging, and we are reaching a conclusion. There are many plaques that you may call vulnerable. It's the burden of disease that really counts. And I think we have to really go into what we already know. I think to go into single plaques with PCI, it is not appealing anyway.
Right.
Thank you. All right, now we go to other aspect of coronary artery disease. This is the so-called ORBITA-COSMIC study. Interesting title. This study is in the Lancet under the title of Coronary Sinus Reducer for the Treatment of Refractory Angina. This was presented by Dr. Michael Foley from Imperial College in London. Well, I have to tell you, I had two patients not too long ago with significant angina like here. These are angina class 3, who have, the majority had already interventions before. And the patients wanted to feel better, and I sent patients to a single institution in Europe, and they said everything is going to work out, and it didn't work out at all anyway. So my experience is not good, so I got into this paper and let's see what we have to say, because this is a significant number of patients. I'm going to ask you first, what is this coronary sinus reducer and how it works?
So I'm biased.
Because
this is
you are
my
in
study
London.
and my study.
Yeah.
So I'm going to tell you, I came into this trial as a skeptic. This was a trial that we designed, was funded by the Medical Research Council. We had no support from industry. I wanted to understand why a device that pertained to work on the venous circulation would ever have any impact on angina symptoms. It's hypothesized to improve myocardial perfusion and perhaps redistribute myocardial perfusion from the epicardium to the endocardium.
So better oxygen uptake in a way.
Exactly.
Yeah.
By narrowing the coronary sinus and essentially reducing flow in that coronary sinus, which may then have that kind of backflow effect on the rest of the system. This wasn't intuitive to me, and I wanted to understand how it worked. And so one of our endpoints was a primary imaging endpoint to understand if genuinely myocardial perfusion on MRI changed. And the second was, does it genuinely improve symptoms with a primary symptom outcome? And we were totally shocked by the results.
Okay, let me go over before you go.
Well, that was a teaser. We're all three sitting here on that was a
She's
perfect
the ringer
setup.
in the
Let's see
group.
what happened. Well, there were 25 patients that had this device approach, and 26 were placebo. Can you tell us how was the placebo done?
Yeah, so as is always the kind of ORBITA standard, it's a pretty high
people
bar
knew.
of placebo. So they were listening to music on headphones. They had all of the same steps in both arms, so right internal jugular access. They then had sedation until they were at a deep level of conscious sedation, so fast asleep before we randomized them.
So basically, they look at angina, different ways, frequency of angina, quality of life, and so forth. And there's a stress perfusion with magnetic resonance imaging. So this is basically what they look at the endpoints. Let me give you the results. When you talk about odds ratio, you really don't know exactly what the figures are, but the primary symptom outcome, which is angina frequency, the odds ratio was 1.4. Okay, the treated group versus the placebo group, so it was positive. Treadmill exercise time was looked at, and actually there was an increment of 40 seconds, and I was thinking, 40 seconds, what is 40 seconds? Well, 40 seconds, is less than 1 minute. You can walk more. This is the result. Then they look at the quality of life in general. The hazard ratio was 0.6. And then they look at the magnetic resonance imaging, and there is no improvement in transmural myocardial perfusion, but there's improvement in subendocardial perfusion. So the results suggest reduction in angina frequency and improved heart disease-related quality of life. That's basically what this study shows. I don't have the meticulous data that you need to really judge this paper properly, but I like to have your opinion, since you are in that place and you know people well.
So this is a population of patients who have significant burden of angina episodes. Many of our patients had some above 6 episodes of angina a day. And what we found was that this device reduced that frequency of angina. Very few patients became angina-free, but they did become less symptomatic. And initially I obviously thought maybe that's just one endpoint, but it was actually consistent across a variety of different symptom and quality of life endpoints. However, we didn't really work out how it worked. The overall myocardial perfusion didn't change, but there was this redistribution signal. Of course, one of the secondary endpoints, but that's where we're going to do quite a lot more study to work out if that's truly how it works.
Okay, Dr. Thourani, what do you think?
I think when I walk away from this, first of all, I love new technology. I like new ideas to improve patient quality of life. At the end of the day, we're all doing this for mortality benefit and our patients to feel better. That's why we do all of the work that we do. So for me, it's stay tuned. I want to see more data on this. I want to see the mechanism figured out a little bit more. I'm still a little bit soft on understanding how that mechanistically improves angina. And so for me, I walk away saying, stay tuned. Are we ready to do it worldwide all of a sudden for everybody? Probably not, but I think you need more data to show how we can do this.
We all have these patients with severe angina that you don't know what to do.
Right.
And this may be a possibility. What about perhaps in patients even with microvascular disease, which are they are there and you don't know what to do? So maybe a mechanical approach. Anyway, it's interesting. So what do you think?
I'm going to be just the last foil to here as an electrophysiologist. The coronary sinus is our gateway. We put catheters in to examine atrial flutter. We put in biventricular pacemakers. Once you release a new device, there's going to be a lot of buzz to put it into people that may not have been the patient population that was initially studied. It's no longer the refractory and just like, oh, we need to take a nitro. And I would just say, coordination with all of our colleagues is so important with technology.
Good. Well, your final word. You like summaries.
Keep working.
That's good. All right, let's keep working.
But I like your perspective.
Yeah, that's
Thank
an
you.
interesting. It's important.
Good point. Thank you. The next, the final, because we don't have more time, is the hypertrophic cardiomyopathy paper, which is interesting. This is safety and efficacy of metabolic modulation with 9 FACC in non-obstructive hypertrophic cardiomyopathy, a new drug. Well, basically, in hypertrophic non-obstructive cardiomyopathy, what we have is a lot of energy expenditure, but it's not spent diastole, and that's the problem. It's like a homeostasis is completely wrong. Lot of needs and not being used. And here we have a drug that they says that's the opposite. Okay, there are not many details about it, and they tested this drug, and this is actually the study. Patients with hypertrophic cardiomyopathy in left ventricular outflow gradient less than 30 millimeters of mercury, ejection fraction equal to more than 50%, and a peak VO2 less than 80% predicted, were randomized to 9-Rafstat, 200 milligrams twice daily, or placebo for 12 weeks. Primary endpoint was safety and tolerability, with efficacy outcomes also being assessed as secondary endpoints. A total of 67 patients entered into the study. They were enrolled in 12 centers. Serious adverse events occurred in 11% of the patients treated with the drug and 6% on patients treated with placebo. This is interesting because you see, you are worried about the drug is causing problems, and actually I look at what kinds of problems are those, and diverticulitis, pyelonephritis, need for CABG, COVID-19 increase. So were certainly important aspects that I think. On the other hand, we have that from baseline to 12 weeks, this drug was associated with significantly better ventilatory efficiency. And I'd like to comment here on the results more precisely. In terms of heart failure symptoms, they look at the Kansas City questionnaire or scoring system, and they move from 67 to 72 in the group treated with the drug, and 73 to 74 in the group treated with placebo. Restricting this in a post-hoc analysis to the subgroup who have more significant symptoms, the movement of scoring was 52 to 64 in the treated drug versus 59 to 61 in the placebo. Cardiopulmonary exercise testing, really very questionable. Cardiac biomarkers, no change. Echocardiographic markers of diastolic function, not much. So, Clyde, what do you think about a situation with something? We have nothing for this particular entity, hypertrophic cardiomyopathy, non-obstructive. You know the data of this presentation. What do you think?
I'm a little disappointed. The problem that we need to solve is real. Patients with an HCM phenotype, not obstructive, they can't go to the operating room, we can't do any other procedures, they're not indicated for therapies that now are available, but they have symptoms. So I wanted this to be stronger than it is. Maybe it's just the first version, but I'm a little disappointed.
What do you think?
No, I agree. It was, it's a bit disappointing, just an improvement in ventilatory efficiency, and more needs to be understood.
Yeah, so look, this is not my space, but what I'm going to say is we see these patients, right? And we see these patients, we refer them on, and we hope that there's going to be something for them in the future. And I think, I don't know whether there's more work on this drug or whether actually this mechanism of action is not going to be the direction and we need to look for other places.
Okay. Dr. Thourani?
First of all, I'm glad that we're spending some energy on the intraventricular septum. And we've made a lot of progress, I think, over the last 5 years. It used to just be the steel, and now we're moving into really innovative ideas and new drugs. For this specific drug and this specific entity, I'm not sure I'm convinced that I would do anything different. And hopefully they won't be discouraged, and they'll continue to change the drug, modulate the drug, and continue to work on this, because it's a real phenomenon. But I'm glad that we're spending energy on the intraventricular septum.
But you said the right word. I see these patients.
Right.
And they come to the office discouraged and they leave discouraged because they realize that others with HCM are receiving novel therapies and feeling better.
Right.
And we're just limping along.
So we have to continue to work on it.
We have to keep working.
Right, that's right.
Well, this is the end of the hour. There are other interesting papers. I would say beta blockers after myocardial infarction with normal ejection fraction not needed.
Yeah.
Chelating therapy, no. And finally, transcatheter aortic valve implantation versus surgical aortic valve replacement in patients at low to intermediate risk. Well, there is a movement there. Anyway, I think I would like to ask a final question to each of you, and I start with you, Julia. What is the most impressive presentation of the papers that we discussed today that you would choose as saying, you know, something is going on here, I want to be...
Actually, I was... I enjoy the conversations that I don't have one particular one. I want to thank all of you for opening my eyes. I'm going to turn this around and having this conversation. We talked about different trials. Mostly, I think we had negative things to say, and a lot of I want to learn more about. You turned my eyes around for the hypertension trial. And so I want to just say thank you for having me. I'm going to say it that way.
Excellent. Thank you, Clyde.
It's less the trials and more the spirit. The idea that we continue to explore discovery science is so robust. We're willing to try different things, different techniques, different devices, different drugs. And I'm just fascinated with the science. That really is the answer to every question. If we keep exploring the science, we'll eventually get there. It's not disappointing that some things are not overwhelmingly positive. It's reassuring that we have a direction and we keep working.
Thank you.
Yeah, so for me, the trial I was going to choose, if I was going to give someone the prize, would be a subcut injection for hypertension. That, for me, is the most exciting trial. But in terms of how my practice changes next week, a trial we didn't discuss, but what is REDUCE-MI? You know, will I be giving beta blockers post-MI to patients with preserved EF? No. And importantly, what excited me most about that trial was that there was a story, there was an answer, but we retested it in a new era of primary angioplasty, etc., and we got a new result. And it's great that we can retest old theories.
That's true. Yeah.
Be careful how you define LV dysfunction. That's my lens.
That's a good point. Yeah.
I also like the hypertension trial. To me, that I walk away saying we have to do something to make it easier for our patients. So that resonates with me a little bit more. But I like really what Julia said. Which was, we talked about a coronary sinus technology, but yet EP said, hey, be careful. We all need to look at it together. And what that makes me think about is a heart team. And we're so stuck in our silos that sometimes we forget what other specialties and other part of the heart need to have that collaboration. So, Julia, I walk away with what you said. That kind of resonates with me also.
Thank you. Well, I think it's true. It was an educational kind of an enterprise, this meeting. It makes you to think on a number of issues that are new, interesting, exciting. And I think this is probably a good summary of the meeting. Well, to me, the best has been you today. It's been a very interesting interaction. Very nice of you to really participate. And, you know, all the questions that I have and the questions that you have were quite pertinent, and I feel very pleased to have been with you this morning. Thank you. And to you, the audience, here we are. As another national meeting, we think we concluded that from the educational point of view was top, important, and I wish you the best until we come back again with this hour of summary in the next proximal meeting. Probably will be the European Society of Cardiology meeting in London. Thank you.